Hello, my name is Dr. Elliot Friedman. I'm the Division Chief of Hematology and Medical Oncology at the Lehigh Valley Health Network in Allentown, Pennsylvania. I'm also the Director of our Thoracic Oncology program. Today, I would like to discuss our recent article entitled The Effectiveness of a Thoracic Multidisciplinary Clinic in the Treatment of Stage III Non-Small Cell Lung Cancer. The American Society of Clinical Oncology, the European Society of Medical Oncology, and the Institute of Medicine all promote a multidisciplinary approach for the treatment of cancer. This is especially applicable to the care of patients with Stage III non-small cell lung cancer, where all three treatment modalities, medical oncology, radiation oncology, and thoracic surgery, as well as pulmonary medicine, play a vital role in determining appropriate coordinated treatment plans. We have developed multidisciplinary clinics at our institution for many different malignancies, including breast cancer, malignant melanoma, pancreaticobiliary malignancies, prostate cancer, as well as lung cancer. However, not all patients seen at the Lehigh Valley Health Network are seen in these multidisciplinary settings. When a patient is first seen depends on the referral pattern of the primary care provider and which treating doctor gets the call to see the patient. For the purpose of this paper, we reviewed all cases of Stage III non-small cell lung cancer seen at our institution between March 2010 and March 2013. We compared the care that patients received when referred to the Thoracic Multidisciplinary Clinic to the care that they received when they were referred to individual providers. The names of the patients with Stage III non-small cell lung cancer were gleaned from our tumor registry, and the diagnosis of Stage III lung cancer was confirmed by one of the physicians participating in the multidisciplinary clinic. 220 patients with Stage III non-small cell lung cancer were identified. 64 patients were excluded. The reasons for exclusion are listed on this slide. The remaining 156 patients were initially seen in either the Thoracic Multidisciplinary Clinic, in an outpatient physician's office, or during hospitalization. Those patients seen in the hospital were also excluded from this analysis. A breakdown of those patients seen outside the MDC is demonstrated on the next slide. 27 patients were initially seen by a thoracic surgeon. 21 of these patients were taken directly to surgery without additional consultation with other specialties. 24 patients were initially seen by medical oncology. 4 were referred to the thoracic surgeon. 16 received upfront chemotherapy or combined modality chemoradiation therapy, and 4 were directly referred to hospice services. 6 patients were initially seen by radiation oncology. 4 received radiation, and 2 received combination chemoradiation. Over the course of 3 years, the percentage of patients seen in the thoracic MDC rose. This is demonstrated on our next slide. We recorded the date of the initial radiographic study where the malignancy was discovered, the date of the first biopsy, the date that the patient was seen by a treating physician either in the clinic or not in the clinic, labeled first touch, and the date that therapy started. We also monitored adherence to our institutional clinical pathways for treatment of Stage III non-small cell lung cancer, outmigration of patients to other institutions, and overall survival data. Time intervals to initiation of treatment are demonstrated on our next slide. You can see that there is no difference between patients seen in the MDC as opposed to non-MDC patients in the time from initial radiographic study to the start of treatment, averaging between 50 to 60 days. Similarly, there is no difference in the time interval from bronchoscopy or other biopsy to the start of treatment, averaging about 35 days. However, once seen by a treating physician, patients seen in the multidisciplinary clinic were treated in approximately 20 days as compared with nearly 30 days when not seen in the clinic. The next slide compares other parameters of patient care between our 2 patient cohorts. There was a statistically significant improvement in mediastinal staging, adherence to clinical pathways, examination by more than one treating physician, and patients remaining within the LVHN network when they were seen in the MDC. Our institutional clinical pathway for treatment of Stage III non-small cell lung cancer incorporates bimodality, concomitant chemoradiation therapy, either as neoadjuvant treatment or definitive treatment. We also noted an increase in unsuspected N2 disease in patients not seen in the MDC. This relates to a large percentage of non-MDC patients first being seen by thoracic surgery and then being taken to surgery with inadequate preoperative pathological staging. It correlates with the higher incidence of mediastinal staging in MDC patients. Finally, median overall survival in MDC patients was 17 months and in non-MDC patients 14 months. This approached statistical significance. In conclusion, we have demonstrated an overall improvement in the quality of care that our patients with stage 3 non-small cell lung cancer receive when seen in our thoracic MDC. Our goals moving forward are to increase the percentage of patients with this stage of lung cancer that is seen in the MDC. Additionally, as we move more lung cancer patients to the MDC setting, we hope to decrease the time interval between initial radiographic diagnosis and pathology to first touch by physicians and ultimate start of treatment. Thank you.